Hello friends, myself Dr. Sushma Deshmukh, IVF specialist and hysteroscopist from Nagpur. At the outset, I would like to thank JP Publications, which is my family, for giving me this honor to present or share my views regarding Hirsutism and PCOS. We all know that the Hirsutism and PCOS are two different entities, but they are linked to each other. And here we are going to learn the different aspects of these two things. What do you mean by hirsutism? It is defined as an abnormal amount of terminal hair in male pattern distribution in women. And hirsutism is the main manifestation of hyperandrogenism in women with PCOS, that is Polycystic Ovarian Syndrome. 9 to 10% of the young females are having hirsutism, and in 60 to 70% of cases of PCOS is the cause. So one should remember that hirsutism must be differentiated from hypertrichosis. What is hypertrichosis? It is a non-androgen dependent excessive hair growth. So is that clear? But everybody here will agree that the PCOS is a burning issue, because PCOS has involved different medical specialists including gynecologists, then endocrinologists, dermatologists, and those who deal with the metabolic or the cardiovascular disease. So it is a disease of mystery involving multispecialty, leading to controversy, adding to diagnostic dilemma. So if you look at the prevalence of PCOS, day by day it is increasing. In India also, initially it was 3 to 22%, it is now more than that. So whenever we utter word of PCOS, so many things are coming to our mind. Is it a mystery? Always in controversy? Is a sensational entity with hormonal abnormality, with menorrhagia, so many things with the diagnostic variability, but it's a thief of femininity. Why it's a thief of femininity? Because there is hyperandrogenism. And here our discussion is coming that this hyperandrogenism is leading to hirsutism. In PCOS, we do get the evidence of androgen excess. That is a hyperandrogenism, and it is in the form of hirsutism again, then androgenic alopecia, seborrhea, acne, and acanthosis nigricans. But apart from all this manifestation, hirsutism remaining the primary marker of hyperandrogenism. And hirsutism is a common clinical condition seen in the female patients of all ages, especially in PCOS with the androgen dependent excessive hair growth. And the cause is mainly hyperandrogenism, which may be ovarian or the adrenal. But it can be a part of rare metabolic syndrome. Remember, it can be drug induced or just idiopathic. Always, because we can see that it has a really huge psychological impact. It is really disturbing for all young females and the women. The hirsutism is a really problem for these patients. And we need to understand, that's why etiology. Already I mentioned that there is an increasing androgen levels in females from increased production of androgens. That is the testosterone either from the adrenals or due to ovarian disease. The ovarian causes of hyperandrogenism are the mainly polycystic ovarian syndrome, and it can be ovarian tumors. Adrenal causes include Cushing syndromes, then the androgen producing tumors, congenital adrenal hyperplasia. There can be other causes, even hyperprolactemia and drug induced. Always remember that 20% of patients may present with the idiopathic hirsutism with normal androgen levels and the ovarian function. So basically, hirsutism is attributed to the increased production of the or increased sensitivity of the hair follicles to circulating androgen. However, only 1 to 2% of testosterone is in free form and is the active androgen, and only free testosterone is converted to dihydrotestosterone by the enzyme 5-alpha reductase, and which is present in the outer root sheath of the hair follicle. And always we need to know that in humans there are 3 types of hairs. That's the lanugo, vellus, and terminal hair. Lanugo is a very fine hair that covers the fetal body and disappears during the first few weeks of life. Vellus hair is very short, fine, and usually non-pigmented. And in women, terminal hair is found mainly in such areas like eyebrows, eyelashes, scalp, axilla, or the pubic area. But it has always it undergoes the hormonal influence. Then it becomes a problem. That's the the androgen dependent areas. Then we need to evaluate such patients. But it is not only imperative to identify the cause of hirsutism. Remember, it is important to know how to recommend the right treatment based on the main causative factor. And the most important determinant is in making the diagnosis a change in the form and the rate of hair growth. So now coming to the practical approach and evaluation of PCOS with hirsutism. Very simple. Go step by step. Though it looks little bit difficult. If you are going step by step, there is history and symptoms, then clinical examination, ultrasound imaging and the biochemical investigations. So first of all, confirm the diagnosis. Whether the PCOS hairs are localized in male distribution or there is a generalized increase in the growth of the hair all over on the body. There is a hypertrichosis. So we have to see in hirsutism that the hairs are localized in the male distribution pattern. Confirm it and then move further. Detail history including the age of onset, the puberty, middle age, menopause, rate of onset of symptoms. There is a gradual or sudden, history of weight gain or diabetes, then the drug history prior to the onset should be taken. Now coming to the clinical features. Examine the patient properly because hirsutism usually presents with the increased growth of terminal hair at the sides of the face, then upper lip, chin, upper back, shoulders, sternum and upper abdomen. Ferriman and Galway devised a very wonderful score for the clinical quantification of the hirsutism. Now coming to the lab evaluation, there are various tests are there, but testosterone remains a very good marker to know the degree of hirsutism. But always remember, if the level are more than 200 nanogram per ml, then think about a malignant tumor. Then other tests are like the 17-hydroxyprogesterone, then for the test for the Cushing syndrome, then the prolactin level, serum TSH, we need to evaluate in the proper way. Then the ultrasound, it to detect the polycystic ovarian syndrome or the any ovarian neoplasm. MRI, this is the magnetic resonance imaging, is not of importance, but in special cases of the adrenal region, it can be helpful. So coming to the management. Again, management divided in the categorically general treatment with the drugs and the surgery. General. If the drug is the cause, simple withdrawal of the drug is very important. It should be helpful. In PCOS, lifestyle management. Because in obese patient, again there is increased androgen levels, increased hirsutism. So lifestyle management is very important in such patients. Counseling really has a very important role because of hirsutism, they feel low esteem, then the depressed, anxiety is there. So we need to counsel these patients thoroughly. Then the treatment with the drug. Remember that these drugs, they can prevent hair growth, but they cannot remove the previously present hairs. That is especially the oral medication. And the oral contraceptives are the first line of treatment for hirsutism. And nowadays there are very nice combination with these oral contraceptives like androgen receptor blockers like spironolactone, cyproterone acetate, which has a strong progesterogenic and the anti-androgen properties. So we can use in the combination of the estradiol, various market preparations there. But remember, while using spironolactone, always think about exclude the patients who are having renal insufficiency, anuria or the chronic renal problems. Now there are another drugs, the 5-alpha reductase inhibitors like finasteride. They are also found to be effective, especially in the idiopathic hirsutism. Nowadays some creams are there like eflornithine hydrochloride, a new agent which can be used as a topical cream for decreasing the arresting the facial growth in women. But one should be aware of the other aspect of hirsutism like idiopathic already I mentioned, endocrine disorders already I mentioned, effects of drugs and the certain ethnic groups especially Parsi and Sindhi. So, coming to conclusion, hirsutism requires thorough clinical evaluation and investigation for the treatment, lifestyle management for PCOS, but aware of the other aspect of hirsutism, idiopathic hirsutism, oral contraceptive with addition of anti-androgen may be needed for 6 cycles. But remember, in women with the severe hirsutism, combination of the OC pills with hair removal therapy. In this time, we have to consult with the dermatologist. There can be therapies like photo epilation or with the lasers can be a preferred treatment along with the drugs. So, hirsutism is a difficult situation with diagnostic dilemma and confusion. PCOS is also the syndrome giving difficulty in diagnosis, always in dilemma with studies and discussions, troubling adolescent to menopausal ladies, responsible for infertility and affecting justosis. The mild cases we may miss, but moderate to severe cases create great fuss. So be alert, learn and update hirsutism and PCOS, save women and girls. Thank you.